Every claim tells a story, and some are stranger than fiction. Welcome to the F-Files. When claims get weird, we get to work.
Hello, everybody, and welcome back to the F-Files, where we take fraud seriously, but not ourselves. We're your hosts.
I'm Daphne.
And I'm Mandi. And today we're going to talk about services and vans.
Okay, first things first, we have a little bit of a confession to make. The original idea behind this episode was going to be mobile clinics and the services that you could find out of large RV like traveling vans. We did find some interesting services that could be performed in these large vans, like dermatological procedures, radiology services, and some dental services, among others. However, there wasn't a lot of areas that we could decipher for fraud, waste, and abuse because most of these services are allotted for very rural areas and or homeless people who need access to health services. So at that point, we decided that we should pivot and proceed with a different route.
Yeah, so in keeping with the theme of services and vans, we're going to actually talk about non-emergency transportation instead. We want to talk about this because it's a timely topic. In October, the HHS OIG added non-emergency transport to the work plan because they were seeing a lot of fraud, waste, and abuse occurring at the state and federal level. And then also at the National Healthcare Anti-Fraud Association annual training conference in November, they were talking quite a bit about Medicaid issues with non-emergency transport. So to give you a little taste of what's been occurring, I just want to talk a little bit about KMD Ambulance. So this operation was run by two brothers named Kevin and Melvin Davies. They got really creative with their name, KMD. And they ran an ambulance company out of their townhome in a gated community. I don't know about you, Daphne, but just running an ambulance company out of your house is kind of, I don't know, to me, that's a red flag to begin with, but I don't know. What do I know?
Yeah, I would think that they'd have a business location with potentially a garage or a fenced-in area where they might park their vehicles that they use.
Or some signage, I don't know. It's just,
Yeah.
it's a gated community. I don't know. It's just, that's a little odd to me. Anyway, these knuckleheads were billing Medicare, TRICARE, and Medicaid for emergency transport. But what was actually happening is they were moving the patients to dialysis, physical therapy, routine medical appointments, and they weren't using any specialized medical equipment or any emergency medical techs. So some of these patients actually just got right up out of the van and walked into their appointments. And then they also billed for trips that didn't actually take place. So somehow they ended up passing Medicare inspections. I don't quite understand how that happened. The articles did say that they used EMT stand-ins. So I guess they were just kind of paid to, be present so they can pass their inspections, and then they just went away. But anyway, Kevin and Melvin racked up on average about $22,000 per patient. And in total, these these claims came to $6.3 million. And what ended up happening is they were just kind of laundering this into different high value assets like cars, boats, things like that. One of the brothers drove a Porsche Panamera. The other one drove a Mercedes Benz. So basically, they were getting too flashy with their criminal actions and got caught. And obviously, as everyone does, you think about Walter White.
Yeah.
The car wash. I mean, that
Heisenberg.
fly under the radar. He drove a Pontiac. His wife drove this old beaten up. I mean, it wasn't beaten up, but it certainly wasn't a new flashy car. So, I mean, that's a smart way to do it if you're going to do it, but they got a little too flashy. So anyway, they had to forfeit all that stuff. Kevin was sentenced to 12 years in federal prison and Melvin got 10 years. So, Daphne, I know that you're a nurse and I know that you worked in a SNF. So I just wanted to see if you have any stories like this to share.
Yeah, I sure do. I did a very short stint in a SNF. I want to say it was maybe only 3 weeks to a month, but in that short time, I did have to arrange for transports for patients to get back and forth to appointments and medical visits, like dialysis, that kind of a thing. And then this one patient that we had was super friendly. They were really convincing. You could just approach them in the hallway and have a good conversation with this person. So I had arranged a transport to a medical visit, and this patient convinced the van driver to drop them off at the store so that they could do some shopping. And the transport driver did. They did do that. They ended up dropping them off at the store, which was just a couple of blocks from the nursing facility that I was working at the time. So they probably just figured, oh, no big deal. It's just a block or two away. And our patient ended up having a little mishap on the way back to the facility. They were in a wheelchair and they were trying to go up over a curb, and their chair ended up flipping onto the back of it. So, luckily, a good Samaritan happened to be walking by and saw the patient flip over. They flipped them right side up and then made sure that they made it back to the facility. But man, that was an interesting day.
Oh my gosh. That
Lots
would
of
give me a
extra
heart attack.
paperwork.
Yeah. You're there till midnight doing incident reports.
Yeah, yeah. How about you? Do you have any interesting stories?
Kind of, yeah. So similar to you, I had a job once where I had to sort of coordinate transport. So I worked at a behavioral health carve out. This was a Medicaid payer. And one of the things I had to do there was coordinate psych admissions. So if a patient was in the emergency room and they needed to go to a psych hospital, then I would help, arrange that. And in this particular case, it was a kiddo with some compulsive behaviors. This kid had some self injurious compulsions with skin picking. So I had arranged a non emergency BLS because it was a voluntary admission to get him over to another, a pediatric psych hospital, which was clear across the state. So we're talking about a 3-hour trip. So roughly 3 hours later, I call the accepting facility to make sure the kid arrived, and he did not. So
Oh
I did a
no.
little legwork. What the heck happened? Turns out the ambulance crew made a pit stop at McDonald's and got him a drink. And at some point during that trip, the kiddo inserted the McDonald's straw into his urethra. Um,
No.
yeah. So,
Oh no.
uh, I don't know. I mean, if the diameter of a McDonald's straw compared to regular straws is a lot wider. So, the whole thought is just kind of like pretty horrifying. So, turns out they had to like make another pit stop to another ER to the way to the psych hospital to get him assessed. I don't actually know what happened, like if permanent damage was done. That wasn't really information that I was privy to. What I did find out, however, is that they did not use BLS to transport him. They used a wheelchair van. So this kind of gets into, when is BLS appropriate versus wheelchair vans. In this sense, I don't know that he would have had access to that part of his body in a BLS on a stretcher. I know that there are some, straps. I don't know that it would have kind of like pinned down his arms necessarily, but I don't think the act of inserting that straw would have been as easy for him if he were if he were on a stretcher. So these are just kind of disturbing example of what can happen when crews aren't paying attention when they're transporting people, and then of course, submitting bills for something that they're not actually providing. So,
Yeah.
um,
Well, clearly that second person who was supposed to be the attendant wasn't keeping an eye on the kid.
no, I
That's
think like this is
crazy.
before cell phones, so they were probably just listening to their music and talking about their Friday nights or something, and just like, yeah. So,
Yeah, well, I
That's
could
information.
definitely see like the disparity. If they're being transported by a BLS in an ambulance, then the attendant would have to be in the back of the ambulance with the patient. They wouldn't be up front chatting about their weekend plans like they could
Exactly.
do in a transport van, because essentially all a transport van is just a modified van with extra space so that you can put a wheelchair in it.
Exactly. Yeah. Yeah. So maybe talk about some, since we're on that topic, talk about some differences between wheelchair vans and ambulance transports, if you
Oh
don't
yeah,
mind.
sure. I'll go into the wheelchair vans and you can take the ambulance transports.
Okay.
So the wheelchair vans, they are modified. They have a part in the van where they can tie down or anchor the wheelchair to the floor. It's usually like a 4-point tie down. They do have a seat belt, as in a lap belt, and a shoulder harness. They do have an option for attendants to be present, which is typically ideal for patients who might have some mental health issues, like potentially dementia. And then these vehicles are typically used when the patient's medically stable, they're cooperative, they're voluntary services that they're receiving, like routine dialysis and like a hospital discharge to a SNF, that kind of thing.
And then for BLS, the patient is medically stable. They may have some medical concerns. These medical concerns would require them to go in a more supportive environment. So they would be laying on a stretcher. They would have seat belts, like, straps across their chest, their shoulders, their waist, their legs. And, I could be wrong about the exact location, but generally there's at least 3 sets of straps. It's a 2-person crew with a driver and an attendant. The staff qualifications vary by state, but you generally find at least one of the crew members would be a certified emergency medical tech. They'd have basic medical supplies. So these are non invasive things like oxygen. They can do assisted ventilation and suction. For circulation, they could do like, an external defibrillator, check blood pressure, vitals, stethoscope, pulse ox, glucometer, things like that. For trauma, they have dressing supplies for wounds. They have tourniquets, immobilizers, splints for fractures, limited medications like aspirin, glucose, EpiPens, Narcan. The thing with BLS that should be pointed out, though, is it's not for convenience. So it shouldn't be used in lieu of a private car, taxi, Uber, or a wheelchair van. So if the patient's condition does not have criteria for BLS, they should be transported some other way, whether that be private pay, wheelchair van, private pay BLS is fine, but you can't bill the insurance for something that's for convenience. Medicare is only going to cover it if the patient's health would be negatively impacted if they're transported by other means. So one of the criteria is that they're bedbound. What bedbound means is that they're a full 2-person assist with their transfers. They can't ambulate. They can't sit upright in their wheelchair for the duration of the transport. And they usually require some other criteria in addition to that. So maybe they need oxygen and they can't self-regulate it. Maybe they have stage 3 or stage 4 pressure ulcer on their sacrum, their coccyx, their sit bone, spine, or some other area that makes contact with the surface. And the reason a stretcher would be needed is that they need sort of positional offloading so that they're not exacerbating that injury. And then the attendant would just monitor the dressings and make sure they remain intact. So another criteria would be fractures. So again, for positioning and maybe pain control, or if they're having some behavioral or safety concerns like self-harm, harm to others, maybe it's an involuntary commitment and they're a flight risk. By the way, they do have soft restraints on BLS, and they can be used if required. There are rules around that. If the patient's physically combative, though, there things occur, which is why you need 2 techs with BLS, not just the driver. You need somebody in the back to, keep the patient calm, explain what's happening, and make sure that they arrive to their destination safely.
Yeah, that all makes sense. When you say BLS, I feel like you might mean ambulance, just in a generalized statement. Is that right?
Yeah, so like I said before, I mean, when you look, BLS is okay, wheelchair van is like a, you know, a van. And usually there's a, you know, there's a ramp that comes out with a lift and it lifts the wheelchair in. So it's a large van. BLS is what you traditionally think of as an ambulance. Um, BLS stands for basic life support, and that's the service that's being provided. It's not necessarily the type of truck they're using or van. It's the
Okay.
service that's being provided.
Okay. That makes sense. Thank you for the clarification.
You're welcome. And thank you for asking.
Yes. Okay, let's talk about some types of schemes. Upcoding is always an issue. I think that that's kind of a scheme amongst many different areas in the medical field, but particularly for ambulances or transports, as we're speaking of today, they could be billing a basic life support service as an advanced life support service when only basic life support was necessary. So you can't bill for more than you're providing, obviously. They could also be upcoding a wheelchair van as an ambulance, which would be the BLS or the ALS codes. When a patient's stable and transported safely in a less expensive wheelchair van or taxi, the patient can walk or ambulate to or from the ambulance or sit up in a wheelchair or private vehicles. That is should be billed as a wheelchair van, not an ambulance. And Mandy, I'm curious, did you know that they have different levels of support that can be provided in non-emergent transports, like a wheelchair van?
No, I didn't. Tell me about
Yeah,
that.
they have different codes for basic life support and advanced life support. It's not on this. I think I have it on the other one that I have. I'll have to go back and look at the codes so I can tell you.
Okay, but that's interesting. So, basic life support in a wheelchair van. And so I
Yes.
understand now why you were asking for clarification between BLS and ambulance. So that just kind of further clarifies that when we say BLS, we're talking about a service. We're not actually talking about the type of vehicle that was used. And just briefly, like, could you clarify what you mean by ALS, advanced life
Yes,
support?
advanced life support. Yeah. So, advanced life support differs from basic life support in the sense that you have to have more certifications and education about how to provide services to patients who might require a higher level of service. A lot of times, these advanced life support providers are able to do things like insert an IV, maybe provide some additional support for wound care if there's some issues with that, those
So
kind of things.
we're talking like more invasive care than you would get,
Yes.
okay, with BLS. Gotcha. Okay. And then, okay, back to schemes. Something else to look out for would be falsifying medical necessity. And this is where someone might misrepresent the patient's clinical condition on the physician certification statement, which is commonly called the PCS. So, this, you know, I have a little bit of experience with that, not with falsifying it, but certainly working in an atmosphere where there was a lot of pressure to do so. So I am a social worker. I worked in case management and acute care for a long time. And one of my jobs doing that was to help patients get home sometimes, especially with elderly patients who had stairs to get into their home. You know, after the hospital, that could be a little tricky. So if you have like 8 stairs to just get to your front door, and you have nobody to help you in, sometimes you need help. But the issue was that they couldn't afford to pay for, you know, ambulance themselves. They wanted to bill the insurance. So there was a lot of pressure to come up with some criteria to help them get that covered by insurance. And that pressure just didn't come from patients, it also came from hospital staff. and there was always a pressure to kind of turn over the beds because of the demand in the ER. You gotta get people discharged so that we could admit people, and barriers like this were not tolerated well. So that was a really stressful situation, always kind of being in a situation where I'm having to tell people it could cost you, $3, $4, $500, but I can arrange it. I'm happy to arrange it. I just want you to know you're going to get a bill. And then, just saying, well, I've got they could argue, well, I have this pressure ulcer, and I could say, well, yeah, but it's like, it's not, I mean, it's a stage 2, and you're not sitting on it. Like it's on the top of your leg or something. I don't know. I mean, I'm just making stuff up right now, but it's like the criteria is very, very specific. And I will say, hospital discharges are a ripe area for data mining for this sort of scheme.
Yeah, that's tough. When you're having to arrange transports for people who are on Medicare or Medicaid, a lot of times they're on a fixed income. So I think coming up with a dollars for a massive ambulance bill could be pretty significant for them. But going back to your scheme of medical necessity,
Mhm.
I was reading the Medicare Claims Processing Manual, Chapter 15 for ambulances. And did you know that it says that even though there's an order for services for transports, that doesn't necessarily mean it's going to be covered?
Yeah, I mean, and that's something that people should be very transparent about. So even if filling out this form, back in my previous life doing this type of work, um, I could think they have criteria. I could believe it. I could write it all out on the form, but that's no guarantee that insurance is going to pay for it. So the patient should always be notified that there's a possibility of them getting a bill.
Yeah, yeah, and especially with an issue, like this, where you mentioned that HHSOIG is looking at this more closely. All it's gonna take is one little audit, and, you could
Yeah.
be in some hot water.
Yeah, and right now everybody's looking at this really closely, which is kind of why we're talking about it. So, yeah, people really need to be on their best behavior. Well, they should be
Yeah,
doing
for
that
sure.
anyway, but like, heads up, people, do better.
Okay, another scheme that we've thought about and talked about a little bit is falsifying mileage. So, is the mileage directly from one point to another, which would be the point of pickup to the point of drop off? Or are they adding in some pit stops along the way? Are they taking the scenic route to look at the fall foliage or maybe some waterfalls along the way? It's kind of a known scheme in this transport industry to increase the billable mileage as much as possible. So that's definitely something you're going to want to look at.
Yeah, definitely. And then something else will be kickbacks. So this could look like a few things, but either A, recruiting patients and paying them to use the service. So, for instance, like with KMD ambulance, maybe they were paying some of those dialysis patients to use their service so they could bill Medicare, get reimbursed quite a bit. And, paying the patients like $50 a week was nothing compared to what they were being reimbursed. So, that would be option A. Option B would be like if a facility is paying a crew to route transports to their ER versus another ER.
Yeah, I could see kickbacks being a kind of a big deal, especially as we're talking about Medicare and Medicaid patients, because being on a fixed income can be tough, especially in today's economy. So having an extra, I don't know, you used $50 as an example a week could really be attractive to somebody.
Oh, absolutely. Yeah. I mean, and they need a ride to dialysis anyway, probably. So it's like you're getting paid to go. It's perfect.
Yeah, they
Um,
probably see it as a win-win.
yeah. And then another scheme to keep an eye on is when the crew is unlicensed. So Daphne had mentioned that, these staff have to have proper certification. There has to be at least one emergency medical tech on the crew, and then there are other certifications required as well. But, I don't know if KMD didn't, right? They paid people to sit in as their EMTs. So clearly that's a perfect example where they weren't qualified to do this type of work. They didn't have the certifications. There's also the issue of vehicle permits. So is the vehicle you're transporting patients in, is it equipped to provide medical care, basic or advanced? So those are some things to keep an eye out for. Although I don't know how you would really data mine for that. It's something you'd really have to do with your record request. Just maybe ask for that documentation when you request records.
License and registration, please.
Yeah, and just for clarification purposes, when you say staff lacks proper certifications, you mean in an ambulance transport, correct? Not a wheelchair van.
Yeah, I'm so sorry. Yeah.
Okay. Okay, cool. All right, let's talk about some data mining. My favorite thing to do. For ambulance providers, you're going to look for outliers who are billing for advanced life support services more frequently than they're billing for basic life support services. This is pretty common among most of the clients that I've looked in, Mandy. I don't know about you, but I see that quite frequently.
Yeah.
And one other thing that I notice is sometimes they bill fewer claims for advanced life support services than they do the BLS, but because they're paid at a higher rate, they're ranking higher for the advanced life support services. Do you run across that sometimes?
I do. Yep, that's spot on.
Okay, cool. And then once you've identified an outlier, you could take it a step further and see if the diagnosis code billed for the claim supports the level of service. That's not always a foolproof measure. My understanding is that sometimes ambulance providers will bill under the diagnosis that's suggested by the dispatch center. So it could be hit or miss whether or not that's the actual diagnosis for the member. But it's definitely something you could keep an eye out for. If you have somebody who's being transported for a fever and they're getting advanced life support, that could be pretty questionable depending on what services were provided. If they're like super dehydrated, then yeah, I could see maybe an advanced. But if they're just provided with like a cold pack or a wet towel to put across their forehead, that might be questionable.
What about think about the diagnosis? Sorry, Daphne. Sorry to interrupt, but I do have a question. Dizziness and giddiness. I see that one a lot with ambulance companies for ALS.
Yeah. So for that one, I question that a lot when I run across it. And the reason is because there could be so many different things that have dizziness and giddiness as a what do you call it? Like an R code, a symptom rather than an actual diagnosis. It could be related to some type of anxiety. It could be related to some type of maybe psychosis. It could be related to even I've heard heart attacks. People can sometimes feel that way. So
Interesting.
for that one, it's super questionable. I would definitely request records if you're seeing that as like the most common diagnosis code just to verify and make sure that it's being applied correctly.
Okay.
Some common HCPCS codes for the ambulance specific providers, and these came from the Medicare Claims Processing Manual, Chapter 15, covering ambulances. For ALS services are A0427 and A0433, and these are delineated by different service levels. There's a level 1 and a level 2. Level 2 is going to be more, the patient requires more traumatic care than the level 1. For BLS services, the code would be A0429, and then mileage is billed under HCPCS code A0425, and that's for both ALS or BLS services. There's no difference in the mileage code between the two. The next thing you're going to want to look at is the modifiers that are billed on the claims. Ambulance providers should be appending a modifier that describes the location that the patient was picked up and then where the patient was dropped off. The website for Centers for Medicare and Medicaid Services, or CMS for short, provides a list of designated codes for that. For instance, if a patient's being transported from their residence to a hospital, the correct modifier would be RH. Now, that's not to say that every single modifier begins with the first letter of the name of the place where they're being transported from or to is going to start that way. For instance, like R for residence and H for hospital. I think dialysis is actually J, if I remember correctly. But definitely, if you're looking at this, pull up that CMS website and have the list handy so that you can look at it for reference when you're data mining, see where these people are being taken to. The next thing you're going to want to look at is the mileage between the pickup location and the destination location. I like to use an online map service to verify the mileage between one point to another. That's pretty helpful just to kind of see if maybe they're increasing the mileage inappropriately. And as a side note, emergency ambulance transport should be taking the patient to the nearest facility that can address the emergency issue that the patient's having. If you're looking at an online map and see that an ambulance passed by 4 other hospitals on the route to where the patient was delivered to, I'd look a little bit closer at why that might be. There are instances where like a hospital's full at full capacity, so they're saying transport a patient to the next one over, but it should be the nearest one.
Could be kickbacks too.
Oh yeah, that's a great call too. Yeah. All right, so there's not a whole lot of differences at what you're going to be looking at for non-emergent transports versus ambulance transports. The data mining will be largely the same. There's just a couple things that you might look at a little bit differently. But again, you're going to look for those outliers with the paid claims more often for ALS versus BLS services. Those HCPCS codes, again, per the Medicare Claims Processing Manual, are A0426 for ALS non-emergency transports and A0428 for BLS non-emergency transports. Again, mileage is billed with HCPCS code A0425. So that's the only code that kind of remains the same throughout this chapter in the claims processing manual. There should still be modifiers appended, even if it's a non-emergent transport. So you're going to want to have that list pulled up. For instance, if they were being picked up from their home and dropped off at a non-hospital-based dialysis facility, the correct modifier would be RJ. So just make sure they're billing it properly. And then check the mileage between the pickup and drop-off locations. Again, did they take the scenic route to look at the fall leaves? Did they maybe stop off at a Mickey D's for a cheeseburger or a shake? If that's the case, they billed for that mileage and it'll be reflected in the claims. I personally once found a non-emergent transport that billed over 400 miles one way while I was data mining. I definitely had some questions about that one and suggested to our client that they take a closer look at that provider. I'm not sure what the instance was where the member was being transported to, but again, per the Medicare Claims Processing Manual, it should be the nearest location to the patient for where the patient can receive the services that are being provided. So if they're going to a podiatrist, they're not going to be going to a podiatrist 4 towns over. It's going to be the one that's 3 blocks from their house.
Wow.
Or it should be, in theory.
Oh my gosh.
An additional step that I take when I'm data mining for non-emergent transports is determining if the patient had a doctor's visit or another scheduled medical visit, like dialysis on the same data service. Again, this is not a foolproof measure, as not all non-emergent transports will be to a specific medical visit. For instance, Medicaid often covers non-emergency transports to, say, pick up a prescription at a pharmacy. So if you're looking at members' dates of service and seeing a whole lot of transports without medical visits, that could be a red flag, and I'd start taking a closer look at that.
They're dropping him off at the grocery store.
Yeah, to do some
Or what?
shopping on the way back to their skilled nursing facility.
Yeah.
If you're using our platform, we have many alerts that help capture many of the schemes that I just discussed.
So Daphne kind of already talked about this. For investigators, you really just have to validate the mileage and the route. So there are open source geographic information systems tools out there to use. Google Maps is probably the easiest tool, I would think. Bing has their own version of that. There's QGIS, MapQuest. I think that still exists. And USPS has a address verification tool that you could use just to make sure that it's an actual legitimate address. As far as documentation goes, you should always check the patient's condition at the time of the pickup against the transport level and the route. This not only includes the physician's certification statement, but it also includes the ED notes, the physical therapy notes, the wound care notes, like any sort of relevant notes speaking to the patient's medical condition and mental status leading up to the transport or directly after the transport. And cross-reference all of that against the run sheet to make sure it's consistent with the care provided. Maybe when you're requesting records, also ask for crew certifications and vehicle permits, things like that, just to make sure that the equipment itself is legitimate. Also assess for patterns. So I would look, for certain times of day, days per week, and cross-reference those between patients and just try to see if there's any magically predictable emergencies happening. That's a good indicator that it's a routine transport being sort of upcoded to an emergency transport. I would also check social media. Did the patient take any selfies of themselves sitting upright on Facebook when the certification statement said that they were bedbound? So I think that, there's so much more we could talk about, but I think that's a good sort of introduction to the topic. Gives everyone some things to work with on their end to investigate this.
Yeah, and of course, everything's going to be subjective to what it is that you're seeing in the records and in the data.
And the state rules, the state rules for EMTs and permits and things, it all varies. So
Okay, go ahead. Sorry.
you want to close this out?
Sure. That concludes this episode of the F Files. If you like this episode, make sure to follow, leave us a review, or share it with your other SIU friends. Also, if you have a case or a weird claim you'd like us to explore, send it our way. We'd love to check it out. We love listener submissions as much as we love spreadsheets. So anything you want us to talk about or consider, or if you just have something interesting to bring up, that maybe we could share on an episode, or if you just want us to know personally, we would love to explore that with you.
And before we wrap it, I wanted to inform the listeners of a few events. So first, Healthcare Fraud Shield is hosting a webinar on the 2026 code changes. So that's going to occur on Wednesday, January 21st at 2 p.m. We'll also go over some fraud, waste, and abuse predictions in that webinar. Folks can register on our website or from our LinkedIn. I also wanted to tell everyone about Healthcare Fraud Shield Elevate, which is our user and industry conference in Austin, Texas this April. Our guest speaker is going to be Tyler Schultz, who's the Theranos whistleblower. So we're super excited to meet him and hear from him. At this conference, we'll break down real fraud cases, we'll discuss top schemes, and we'll provide insights and strategies you can take back to your team. And the best part is that it's totally free to attend. So whether you're in an SIU, payment integrity, compliance, analytics, this is your crowd. Spots are filling up really fast, so email info@healthcarefraudshield.com and we can get you registered. Everything that has been discussed in this podcast is based on our day-to-day experiences.
Any opinions stated by myself, Mandy, or any guests during the podcast are not necessarily representative of the opinions or views of Healthcare Fraud Shield.